Good afternoon, everyone, and thank you for joining us for our Facebook live stream from Boston Children's Hospital with the Esophageal and Airway Treatment Program. I'd like to first have everyone introduce themselves. My name is Dory Gallagher, and I'm the Program Director for the Esophageal and Airway Treatment Center. I'll turn it over to Dr. Zendejas.
Hey everyone, thanks for joining us. My name is Benjamin Zendejas, and I'm the Surgical Director of the team. It's a pleasure to be joined by a couple more of my colleagues who will tell you who they are.
Hi, everybody. My name is Michael Manfredi. I'm the Medical Director of the Esophageal and Airway Treatment Program. It's an honor being here today.
Hi, everybody. This is Leah Frayne. I'm the Pulmonary Nurse Practitioner with the Esophageal and Airway Treatment Center.
Great. We're going to start with just little introductions. And first, I'm going to turn it over to Dr. Zendejas, who's going to talk about the multidisciplinary approach that we use at Boston Children's Hospital and why we feel it's so important for kids with esophageal atresia as well as tracheobronchomalacia.
Thanks, Dory. Yeah, we see a variety of patients who come with a spectrum of entities, and there really isn't a particular situation where we would like to isolate them because we think they're all related to each other, and that's why we build our strength with the different members in our team. It's we often hear from families that come to us that they've had isolated or fraction care, and that their specialists weren't talking to each other, and we feel that because we think that's very important in the evaluation and treatment of patients that we see. It can be anything from a child who only has esophageal atresia, meaning a disconnection or an absence of a segment of their esophagus or swallowing tube when they're born, or a child who only has tracheomalacia or weakness of their trachea, or excessive dynamic collapse when they take a breath out, or it can be both or a combination of other things. It's not uncommon for children with esophageal atresia to have the well-known or commonly known Bacterial spectrum, and they may have anorectal problems, cardiac problems, and we like to include specialties that we join forces with as well. The important thing to recognize is that the multidisciplinary care needs to be started from very early on and continued essentially for the long-term care, and a lot of that's what we'll talk about today. What we don't want to see necessarily is that a child may receive the care from only the surgeon at the beginning and then hand it over to the gastroenterologist and never see the surgeon again, and vice versa. The child never meet a pulmonologist until they actually have problems from a breathing standpoint. We want to be proactive. We want to be able to detect problems before they actually occur. And a lot of these issues require ongoing surveillance to be able to manage and detect these issues and to provide optimal quality of care and quality of life for our kids. And so with that in mind, let's keep going with the conversation.
All right, great. I'd like to turn it over to Dr. Manfredi and Leah to talk about recognizing the importance of ongoing and follow-up care. I think you're going to begin, Leah?
Yeah, so I'll talk first about some of the pulmonary symptoms that we see often in our patients and why it's important to follow our patients long-term. Many of our patients come from other parts of the country and world, and we're able to provide care long-term even once they leave Boston, and we do a lot via Zoom and phone calls and things like that. And one of the main reasons that we need to follow up is that we think about the pulmonary symptoms a lot differently, and we take the anatomy into consideration. And many times the pulmonary symptoms can be related to other things like reflux or poor motility or aspiration, and not just something that's straightforward pulmonary from tracheomalacia. So, and that's the other benefit about having a multidisciplinary team, is we can all work together and talk about the different systems that are being affected and what could be the primary culprit of the symptoms so that we can treat them best. And there'll be time later for more specific questions, but I'll turn it over to Dr. Manfredi to talk about some of the important GI follow-up.
Well, thank you. I think a common thing that people believe is that, once, the surgeon puts the esophagus together, everything is okay at that point in time, and that, there should be no problems. But we know from experience that not only can you have issues just at the site where this the surgery was done, where you can have a stricture, but we know that potentially children can have something called a hiatal hernia, where a little bit of stomach is pulled up above the diaphragm, which can make you more prone to reflux. We also, all children with esophageal atresia have some degree of esophageal dysmotility. And these are lifelong issues that we encounter. And these are things that require lifelong care and follow-up. And so those are the things that when patients come to see us in our EAT center, we want to look for signs of gastroesophageal reflux, and we can certainly talk a little bit about that a little bit later on, but also make sure that children are eating fine and eating well. And so I think, things that we look at are how well is your child eating, and how the ease of how they're eating, because it's not just one thing if you're eating all foods, but it takes your child an hour and a half to eat everything. That's not acceptable. That shouldn't be accepted as normal behavior. And so these are things that these are the questions that we specifically will ask when your child comes to see us. We also look for signs of reflux, and we also know that children with esophageal atresia are some of the toughest kids that we know, and their pain threshold is different than our pain threshold. And so they're used to certain levels of discomfort, or don't even feel it because of the way that the way their nerves work, that they don't feel the discomfort from reflux. So we have to find other ways to evaluate this. And then lastly, overall nutrition is something that's very important at our center, and these are things that we would like to keep track of as well. So that's a little brief overview of some of the things that we look at, but we'll certainly get into more with the questions.
Okay. And I know one of the questions that we often get is, do we also follow patients who haven't had surgery at Boston Children's Hospital? And we certainly do, because we do feel our follow-up and multidisciplinary postoperative care is so important for any child that's had esophageal repair or who has tracheomalacia. I know one of the other questions we get about some of the different and innovative approaches that we use here at Boston Children's Hospital, and so and what some of those are for follow-up care as well. So I'll hand that off to Dr. Zendejas and Dr. Manfredi to give just like a brief overview of what we're able to offer.
Thanks, Dory. Yeah, before we get into that, I wanted to make a point too. You're probably wondering, well, you're talking about all this multidisciplinary care, and so what sort of specialist should my child see, or what type of specialist does my child need? And we didn't get into that, but in essence, there's not a right or wrong answer. I think that in general, the pediatric surgeon should be involved in the continuum care. A pediatric gastroenterologist with experience in treating children like this. A pulmonologist would be very valuable adjunct evaluation. Ear, nose, and throat specialists, who work with them all the time, and they're part of our team very closely. Nutritionists, dietitians, feeding therapists are essential in our care as well. Social workers, child psychologists, you name it. I mean, the list could go on, and it really depends on the needs of the child. And so I don't think we should limit ourselves to what specific number of specialists. We're very fortunate that we have all these specialists in our group that day in and day out take care of kids with these issues. But I think let's try to understand what sort of needs the child needs and go from there. But to what Dory was saying is, we're very excited to continuously, the center was sort of founded on innovation and trying to go beyond what was accepted as a norm. The biggest example was sort of tracheomalacia, right? Everybody sort of told you that the child will outgrow that, for example, or for example, for esophageal atresia, that long gap esophageal atresia was something that always needed an esophageal replacement, because it's not possible to put the esophagus together after such long gap. And we've always sort of attempted to innovate in an effort to go not necessarily against that, but trying to offer alternatives for families who need that and want that. And so in a spirit of that, we're continuing to innovate. And one of the biggest things we're doing more recently is we've paid a lot of attention to something that was probably always there. It was, I think, very underdiagnosed or underappreciated, which was vocal cord dysfunction. And by that, I mean children, in order to speak and swallow safely, particularly the swallow component, need that both of the vocal cords, each child has two vocal cords that, in addition to controlling speech, work to prevent swallowing liquids into the airway, if you will. It's kind of like a gatekeeper into the airway. And the nerves that control the vocal cords, the muscles that control the vocal cords, are in the area that we work in all the time. And so every child that has had a prior operation for either esophageal atresia or tracheomalacia are at risk of having had a vocal cord dysfunction, either not necessarily from a complete injury, but sometimes a temporary injury or some sort of a stretch injury. There are different types of injuries, and we can talk forever on that. But the essence is we have to, first of all, assess for that and evaluate in order to treat that. And for the longest time, it sort of was on the back burner for a lot of people, and a lot of people still don't think it's of most importance. And we've tried to change that approach. So first of all, we're checking every child that comes to us for evidence of vocal cord dysfunction. We've seen that up to a third of children who have had an operation of that sort have some degree of vocal cord dysfunction when they come to us. So it's important we take that into account. So what can we do about it? First of all, we can do things to try to prevent them from happening. We're using actively nerve monitoring technology. So there's a special way we can put a special sensor on the breathing tube while the child's undertaking an operation, such that it can alert us when we are close to the nerve or when we're in a situation where we can put the nerve at risk. And so we're doing things to prevent it from happening, and also not just detecting it, but acting on it before they cause symptoms, because that was the other misperception, that most people thought, well, why check if they're not having symptoms? But the truth of the matter is that there's a very high proportion of kids, up to 40% of kids, who have a vocal cord dysfunction and don't have symptoms, or weren't aware that they had a vocal cord dysfunction. And when we do a swallow evaluation, all of a sudden they have silent aspiration. And that can be a source of ongoing respiratory infections and problems. And so that is one area that we're focusing very hard right now to try to diminish the effect that our interventions have on that, and also that going forward we can try to provide better care by identifying these issues and addressing them.
Anything, Dr. Manfredi, on some of the new or more innovative things we're doing?
Sure. So I think that, we've in the past have shown, with our different endoscopic techniques on treating strictures using incisional therapy. We've also probably have the most experience on the use of esophageal stents in children. But some of the things I've been excited about of late is the use of we've been using, something called a DEXA scan, really, because talking about the whole long-term care of our patients. DEXA scan is a special X-ray test to look at bone density, and it's one of the things that I think is something that we're looking into and wanted to check, because again, bone density is something that as we get older, it's harder to increase your bone density as we get older. So if children with esophageal atresia are starting out with lower bone density, we need to intervene early on to help improve that. Also, I know there's a lot of controversy about use of PPI, proton pump inhibitors, and can that affect your bones? And that's something that the DEXA scan can help us kind of better study that long term. Also, we're using a new piece of equipment called the EndoFlip, which is a way to help measure motility in the esophagus, as well as areas that are less distensible. So it's a technology that we're starting to use more frequently. Impedance is not a new technology, but it's something that we do, which is a way to measure acid reflux and non-acid reflux in the esophagus. And it's something that we are doing more routinely in our patients to help predict whether or not children can come off of acid reflux medications.
All right, Dr. Manfredi, to that theme, there's some questions that have been coming in, and one is from a parent who says their child has very little motility, and is there anything that you can do about motility? And second to that, how often do you recommend having EGDs done on children?
Motility, yeah, that's a very, very good questions. So motility, unfortunately, at this point in time, there's no great medications or treatments to kind of improve the motility of the esophagus. That being said, there are certain things we can do to help minimize the symptoms. Sometimes, for example, we notice, the anatomy of the esophagus. For example, some children they may have poor motility, but their esophagus also is very dilated in the upper portion. And so sometimes using, dilating that area. Now, many people say, well, just because your esophagus, like for example, has a normal, the anastomosis is a normal diameter. What we've seen sometimes is doing a little bit of overdilation in those areas can help overcompensate for some motility. So that's one aspect of things. Making sure this, helping improve motility lower down. For example, if some people have issues with chronic constipation, that can affect your upper motility as well. So I think there's ways we look into, the whole picture. So, and obviously we try to optimize things medically to minimize symptoms. And so I think we always take this on a case-by-case basis, but definitely getting a better understanding of the contours of the patient's esophagus and seeing if there's ways we can maximize gravity to help things go through, because gravity is always your child's best friend, especially when kids have poor motility, but sometimes we can help improve that. With respect to, Dory, can you repeat the second part of that question again? I'm sorry about
Sorry, how often you would recommend having EGDs done on children?
Yeah, so if you look at, a couple of years back, some experts got together to talk about, how often should children have EGDs in esophageal treatment. And unfortunately, there was really no great answer. They came up with at least 2 to 3 based on kind of opinion. What we've found is that, we typically recommend that a child should have EGD at least 1 year after their repair to kind of look at the esophagus. Typically at that point, we either will wean the child off of reflux meds or get a baseline on medications to see if there's any evidence of esophagitis. At that point in time, we may or may not consider doing an impedance probe to see if there's any, after the endoscopy, to get a better sense of the reflux component of things. If, and then typically based on the findings, we treat the findings. If there's evidence of esophagitis, inflammation to the esophagus, then we probably would want to repeat a scope in 1 year just to make sure things are improving. And then we would intervene and check. If everything is fine, then we would probably, if everything looked healthy, then we would probably look again in 2 to 3 years. So typically a child should get at least 2 to 3, but what we found is children need more than that. And so I think, typically every 2 to 3 years, children should probably have an endoscopy to look at things. We looked at our information a few years ago, and we published our data, and we looked at over 500 patients, and over half of our patients had evidence of esophagitis on their endoscopy at the time of at their time of their endoscopy, and a lot of them didn't necessarily have symptoms, and some of them were already on reflux medications. So so it's important to get screened and checked. And so that's something that, I feel as a group, we feel very strongly about.
Great, thanks. There's a lot of questions about tracheobronchomalacia, and there were some even prior to we went live today, and some about will a child outgrow. I'll let Leah and Dr. Zendejas, but just to, one question was about their child eats really well and seems from an EA perspective to be doing really well, but has this cough. And I think this brings us to the multidisciplinary approach and what we've been talking about. And one other thing I'll just throw in there is if albuterol is contraindicated.
Oh, yes, I saw that question in the chat. It's probably the number one question that I get asked. So what I would say is that probably 90% of patients that get referred to us to be evaluated for tracheomalacia come already on albuterol. And our thought process behind using albuterol is that tracheomalacia in essence is a floppy airway. Albuterol is a bronchodilator, but it is also a muscle relaxant. So it relaxes the muscle around the airway, potentially making the airway even floppier. So in general, we tend to not use it. There's a subset of patients where it seems to make their symptoms worse. That's a small subset. There's a subset where it just doesn't do anything. So there is also a subset of patients that have tracheomalacia who also seem to have a component of asthma that it actually does work well for. So there's a very small group of patients with tracheomalacia that we do use albuterol for, but in general, we steer clear of it. Dr. Zendejas, were you going to say something?
I'd love to tackle that question about whether tracheomalacia, do they truly outgrow it or not? And the truth of the matter is that that's the common perception of, that's what we get taught in medical school. That if you wait long enough, they'll outgrow it. And the truth of the matter is we don't know that for a fact. Nobody's really done studies to look at that. It's all anecdotal. That's the first sort of fact. The other thing is that there may be some children who grow it out, who outgrow it, but others don't. We've definitely seen teenagers, even adults who have trichomalacia. So in and of itself, age may not necessarily be things. We've also seen kids who with age, it gets worse. I mean, they weren't as bad when they were babies, and then all of a sudden it gets worse. So we've definitely seen that as well. But the biggest question you have to ask yourself is, at what cost? How long, how many pneumonias, how many trips to the hospital, how many respiratory infections, how many blue spells are you willing to wait it out before you intervene on? So we are a lot more proactive on that. And we think one pneumonia is one too much for a child. A child shouldn't get a pneumonia to get some hospitalized if they're otherwise healthy. You know, they can get a respiratory infection, and they all kids will. That if you're having frequent pneumonias, frequent respiratory infections, we have to assess the situation. It may not be trichomalacia. A lot of other sources of chronic respiratory infections that we need to assess. It could be a recurrent esophageal fistula, it could be a laryngeal cleft, it could truly be asthma or croup, as most kids are again labeled as. But we have to assess the situation to be able to treat that. I think you're muted, Dory.
Sorry, I thought I was unmuted. Back to you, Dr. Manfredi. Some questions on reflux, some symptoms of reflux other than vomiting, and another one about the DEXA scan. At what age is that recommended, and is it only if they're currently on a PPI?
Okay, so the DEXA question, we typically start at around age 4. 4 or 5 is typically the age that we would first recommend getting a DEXA scan. I think regardless if you're not on any PPI, I think it's, at age 4 or 5 to get a baseline is probably worthwhile, because it's not just PPIs that can affect things, also your overall nutrition as well, and that's probably even more important than PPIs in terms of bone density, and so I think it's worthwhile. And then if it's at 4 or 5, if it's normal, then you probably don't need another one till you're older, a teenager. But if it's abnormal, then we would get follow-up DEXAs as needed based on after treatment, which again, the mainstay would be vitamin D and exercise and making sure that we're getting adequate nutrition. With regards to PPIs and acid reflux, the main, there's so many different symptoms, and probably I think the most common symptom is a lack of symptoms. Truthfully, a lot of our patients will have no symptoms, but commonly feeding difficulties would be a very common one that we see. So some children who are poor eaters, or they get full very early after they start eating, and then they stop eating because they say they feel full. That may be, it certainly could be that they're full, but it could be that they're having reflux as a sign. Hiccuping, coughing, especially coughing at night when they're laying down, that's another possible symptom. Sometimes, and as kids get older, you can see them that they actually will physically regurgitate a little bit into the back of their throat. There are other subtle things, but again, I think the truth is you can't rely completely on clinical symptoms, and I do think at a baseline you should get at least an endoscopy to see if there's any signs of inflammation, because I can tell you numerous times that patients say they're completely asymptomatic, and then we scope them and we see evidence of inflammation. So yeah, it's definitely something that there are sometimes it's very obvious that your child is having signs of reflux, but it definitely is something that warrants a look. And truthfully, sometimes we may think a child is having reflux symptoms, and there could be other causes, such as if there's some other airway issues, of recurrent fistula, or even asthma, or something that can cause potentially give false signs of reflux. So it may not even we may sometimes be treating patients on medicines for possible reflux when they don't have reflux, and they don't need to actually be on acid reflux medication. So I think the opposite is true too. I mean, I think we definitely take an approach that I know PPI, proton pump inhibitors like Prilosec, Prevacid, get a very bad rap, and there's a lot of studies that potentially show that there's harm to them. But the truth is, they are very safe meds. We do follow kids long term, making sure there's no ill effects from these medications, but we also feel that children should be on medications only if they need to. So we want to test children off of these meds to make sure that they're doing okay. But again, if they need to be on them, I think it's safe for them to be on.
Okay, Dr. Manfredi, there was another question about child to PPI meds, and I think that that was pretty clear by that, unless there's something else that you wanted to add. But also, is a pH test sufficient to determine level of esophageal inflammation, or is a biopsy required? And if so, how often?
Yep. I think you really, I think they both give you different answers. They both address different things. So a pH impedance probe can tell you how frequently the reflux is coming up. And I do feel that when you do a pH probe or pH/impedance probe, because an impedance probe can measure acid and non-acid reflux. So some people may say, okay, you can do this on reflux on a PPI, on a medication. But what we found is because children with esophageal atresia have their motility is lower, the impedance aspect of things is not as accurate. So the pH probe is actually, I think, more useful, but you need to do the test off of reflux meds. And it's not just the amount of reflux episodes that's a factor here, because again, it's all about also esophageal clearance, because you can actually have a normal amount of reflux episodes into your esophagus. If you look at adults have 70 to 80 episodes of reflux in their esophagus daily. Many of us feel it, some of us don't feel it, and that's because we have motility that pushes the reflux back into the stomach. Unfortunately, our children with esophageal atresia, they may have a normal amount of reflux episodes, but because they don't clear it as well, it can cause irritation. And so that's why the pH impedance probe may not give you all the information you need, and that's why an endoscopy can be. They both give you different questions. I think both are useful, but I think definitely an endoscopy will be helpful to tell if there's any injury from reflux. But it doesn't necessarily rule out, if you have a normal endoscopy, it doesn't necessarily rule out that there is some degree of reflux there.
Okay, great. I'm going to switch back over to tracheomalacia, if that's okay. What are some of the causes and flare-ups with tracheobronchomalacia? And also another child saw a pulmonologist, and they basically said we don't do anything or treat anything for tracheomalacia. Is that true? Is there something we can do?
So the primary cause of flare-ups of tracheomalacia are viral infections. And so what happens is a patient will get a viral infection, and tracheomalacia causes an inability to effectively clear secretions from their lower airway, and this predisposes them for bronchitis, prolonged infections, pneumonias, things like that. Other implications can be aspiration. So if liquids are going down the wrong pipe and ending up in the airway instead of the esophagus, in a patient with tracheomalacia, they can't clear those, and so that can cause more symptoms of tracheomalacia as well. So reflux can also do the same thing if they reflux high up enough and then aspirate that reflux. Those are the three primary culprits, with viral illnesses being the number one. In terms of what to do for tracheomalacia, I think the majority of patients are told that there is not anything to do besides allow them to outgrow it. We have a different philosophy here. We've seen, tremendous success with some of our surgical interventions, and many lives changed with the many tracheomalacia surgeries that we have done. So I would say that we definitely think there's something we can do for it.
And to echo Leah's point, is not all kids need an operation. In fact, we try all of our patients first on maximal medical therapy, which includes a combination of sort of medications or nebulizers, usually to decrease secretions or to make them easier to expectorate or to clear. And also some kids need antibiotics. And so some kids, depending on the intensity of the medication and how they respond to it, some children may not need an operation if you're able to control their flare-ups, so to speak, with medication. And so there are a significant proportion of kids that have severe symptoms or persistent or refractory symptoms that do benefit from an operation. And those are potentially kids who have need for positive pressure ventilation, for example. That's one of the indications that we do. Need for a tracheostomy. You want to try to avoid a tracheostomy. If that's the only reason for the tracheostomy, the tracheopexy may be able to avoid a tracheostomy. Other options are blue spells, or these sort of dying spells where the child may pass out and turn blue because they just can't get air in or out. And others are severe recurrent pneumonias and infections. And so all of those things get into account when we do the evaluation, but at the same time, it's not just the symptoms. We also do the evaluation with the bronchoscopy to assess, is there something there that truly matches with the symptoms? And if we see that combination of, okay, on bronchoscopy, we definitely see dynamic intrusion, then we can customize the operative plan, which usually involves some degree of pexy. We can talk about posterior pexy, anterior pexy, combination of both, or some kids need tracheal resections, tracheal splints, et cetera, combination with blood vessel surgery sometimes, or even concomitant issues with the esophagus. And so they are all very customized approaches because each kid is different.
Great, thanks. I've had a few questions here about dilations. How many dilations are normal? If a esophageal dilation was performed and there was a pinhole, and then should they go back? Is that something that we see routinely? And I know Dr. Manfredi can certainly answer this question.
Thank you. It's a good question. I mean, I think certainly if you have a very tight stricture, like a pinhole stricture, you definitely, if your child is dilated, you definitely need a repeat scope pretty soon afterwards, just to see if you've had any improvement. You don't always want to go just based on clinical symptoms if things are improving. Some of that is age dependent. Obviously, if you're an older child, you can tell a little bit more about how they're eating. But if your child is just on a liquid diet, you really can't sometimes tell the difference, because children can really drink through very small openings without any difficulty. So I do think it's important to have follow-up looks. Is there a threshold number that's too many dilations? I think it's a tough question to answer, something that we continue to look at. Obviously, a little bit depends on the type of operation you had and issues around the operation. Some things like having we call it a leak at the time of your surgery sometimes makes you at more risk for more difficult stricturing. Typically after, in our experience, typically after 7 or 8 dilations, and if we're not making any progress, we typically start thinking about what else should we be doing at this point in time. That's what our kind of in our experience with our surgeons and with our experience with our patients, that's something that we've looked at and said, around 7 or 8 is when we start noticing that the benefit return that we're having from the dilations tends to decrease. But we do have patients that can get better after having even more than 7 or 8 dilations. But I do think if you're constantly getting dilated and then every month or 2 it's going back to a pinhole, then I do think you have to think about other options at that point in time.
Okay, great. This is a little, and maybe Dr. Zendejas, you can answer. There are a few questions about genetics. Are we looking for any genetic testing in kids who are born with esophageal atresia, tracheoesophageal fistula?
The short answer is we are not specifically looking at that right now as a research focus. And I know a lot of work has been done on that. And the short answer is there's not a single slam dunk genetic mutation, or is not a particular slam dunk chromosomal abnormality that can explain everything. I think that the thought process behind why these are associated, it has to do with sort of embryology, or how the child develops. And the airway and the esophagus develop from the same sort of foregut butt, it's called. So they develop from the same sort of little area, and then they split into these 2 structures. And so it makes sense that if one has a malformation, the other one is also likely to have some degree of malformation. Historically, however, the surgeons always sort of focused on the esophagus, which is the immediate threat to the life because the child couldn't eat, but the trachea was sort of secondary. And I think now we're starting to realize that they both need to be addressed at the same time. And so I think that's the key to and not just the airway and the esophagus, but all the other structures in the mediastinum, the heart, the vessels, the lungs, et cetera. So we have to look at it as a whole and not just as a single entity.
And again, Dr. Manfredi, there's still a lot of questions about PPIs and when you should wean them off, how long they should stay on. Are there any other follow-up tests for long-term? They understand the DEXA scan, but are there any other blood work test things that you should be looking at? And is there any research on the DEXA scan?
So In terms of PPI, so what our typical process is, children who are on PPI therapy, we tend to do routine lab work on a yearly basis. We will do, we'll check your chemistry panel, we'll check vitamin D levels, iron levels, different vitamins to make sure that there's potentially no interference with absorption of nutrients. Because again, the idea behind this is certain things we eat, require acid to break food down. And if we're decreasing the amount of acid in the stomach, are we affecting absorption of certain nutrients? The truth is PPIs don't neutralize the acid completely. You're still making acid. So most nutrients are absorbed, but we definitely are checking this on a routine basis. And the most common thing we see as deficient is vitamin D. But again, I think that's a tough one because most people in the country, especially if you live in the Northeast where we are somewhat vitamin D deficient because we don't get enough sunshine and we're indoors too much. And so I think, that's something that it's hard to pinpoint that to just being on PPI therapy, but it's something that we are checking all this out. There's not a great, again, we're looking at the DEXA scans we're kind of studying that as well. So I think there's not a lot of data at all in terms of esophageal atresia and DEXA scans, but we are collecting that information, and there will be published data, within probably the next year on our experience with it. And I think it's going to be, bottom line is I do think it's going to be important to have these done to check this out. PPI therapy, typically, we tend to keep children on PPI therapy for the first year of life. Again, depending on, because we do worry about, protecting the esophagus, especially the newly created surgical site, the anastomosis, to make sure there's no, we want to protect that area. So typically we would consider weaning a child off of PPI around a year of life. And so, and again, a lot of it will depend on symptoms at that point. And we tend to get an endoscopy at that point in time at a year of age. And if everything looks normal, we'll take the child off of PPI and then do a repeat endoscopy in 1 to 2 years after that, just to make sure things are still healthy in the esophagus. And then if there's signs of inflammation, then we'll restart the PPI. If they're normal, we'll keep them off of it. So the impedance pH probe can also help be predictive of that. We've had patients who have had normal endoscopies, but then the pH probe shows a high burden of acid reflux, and especially a high burden of difficulty clearing the reflux. And so I think those kids potentially would benefit from that. We can keep you off, some of these kids will put back on reflux meds. Other kids, we will keep them off meds, but then watch them closely and rescope them in a year to make sure that there's no development of signs of esophagitis. The other thing we want to look at it too is, something that, we know that children with esophageal atresia have up to a fourfold amount higher risk of developing Barrett's esophagus. And so, the idea behind that is we want to screen these children for this as well. In our population, we've had over 1%, about 1% of our patients have developed Barrett's esophagus. Which is, again, it's a precancerous condition, something that, again, I do think children need to have these endoscopies just to see if they're at risk for developing this. So again, we didn't really, I know that's not the focus of the day, but it's something that's why I think children should at least have 1 or 2 endoscopies, especially as they get older, before, to make sure that we're not developing this.
Well, Dr. Manfredi, there's actually one question about, have we had any children that did develop cancer? So I think that helps to alleviate some, or if there's anything else you wanted to mention about that.
We definitely, as I said, we've had patients develop Barrett's esophagus as young as 4 years of age. So it's not something that it's not just for teenagers or older or adults. Fortunately, we have not, seen true development of cancer. The good thing about Barrett's esophagus is it's a precancerous condition. If we can watch it, and it's actually treatable endoscopically if caught early, and it's very treatable that way. So that's why that's why we take that proactive approach, that we can identify things before there's a problem.
And then just two more on tracheobronchomalacia. One about adults that actually use CPAP during the day, and why don't we use this on kids postoperatively when they're still struggling. And also a few questions about daycare and things like that, keeping kids out of school. And I know, Leah, you're faced with that question a lot by a lot of parents.
Yeah, the CPAP is a great question. It's something that we have theorized, would be beneficial to our patients. A lot of times we run into insurance issues with it because if they have a normal sleep study, we can't get CPAP approved for just the diagnosis of tracheomalacia. Many of our kids are very small, and it would be and some of the toddlers and smaller kids wouldn't really tolerate the CPAP. So that's something that we haven't really been able to use in the younger patient population. We do have some older teenagers that are going to be trialing it. The school question has been tricky in the setting of COVID. I will say that, none of our patients that got COVID got severely ill that we all know of. None of our patients that had it were even hospitalized, but in terms of school, I did see the note in the question in the chat about the 13-month-old who the doctor had recommended not to go to daycare. That's tricky. I think many times I have recommended in kids less than a year who, were at really high risk for severe illness, from tracheomalacia and possibly other comorbidities such as prematurity, that it would benefit them to be out of daycare for that first year of their life, which is when colds are the hardest to manage. After that, it gets a little bit trickier. If colds do end up with hospitalizations, then I do think you probably have to think about not going to daycare. If it's something that can be managed through aggressive airway clearance regimens, antibiotics, preventative antibiotics, then as the kids get older, I think sometimes you have to think about, the importance of them being around other kids for their development. So that can be a tricky question. I think that answers that.
Thanks, Leah. Well, it looks like we're getting towards the end of our time of the questions. I'm sorry we didn't get to everyone's questions. There were a lot that are very patient-specific or surgery-specific, and we are always happy to answer those questions and do a second opinion if you'd like to call our office. We'll try to get back to as many questions as we can. But I want to thank you, everyone, for joining our webinar this afternoon. If you did not get your question answered, please feel free to reach out to our office. And thanks very much.